spinous process.
To give a talk on OPLL anterior versus posterior surgery.
Okay, so do you see my screen now?
It's not
yet. You must share the screen.
Okay. I have
on the bottom.
You
share screen.
Click the share
screen.
and then open the slide.
Yes. Yeah.
It's okay.
Can you see now? Yeah.
Yeah.
Yes.
Okay. Let me just try to start the slides. Okay, right. So we heard about anterior, posterior, different options. I'm gonna try to recap because more or less this is the last talk that is commenting on the case. So I'm gonna try to give you a few perspectives and my opinion on some questions and hopefully recap all. So just to remind you, this is for the juniors, the basic segment of the spine, the disc and the two adjacent vertebrae. The distribution of the forces, if you remember, in the lumbar spine, about 90% of the forces go anterior and about 10-20% posterior. However, in the cervical spine is flipped. Posterior segments are more loaded with forces. A few biomechanical facts: most mobile segment, about 14 degrees lordosis normally. We said about the weight bearing. Very important that if you violate one level, you have to expect changes in the other levels as well. If you impair the sagittal balance, you trigger that cascade that becomes a vicious circle, and that can give you a lot of troubles. So speaking about the OPLL, also known as Japanese disease, not only because it's confined in Japanese population, but definitely higher in the Asian population. Men are predominant comparing to women. Usually you will see your patients in 5th or 6th decade. The predilection side is cervical spine, followed by thoracic and lumbar. There is histology behind that. There is an enchondral ossification. If you examine your OPLL that you have removed, and there is also genetic predisposition. So, what are the risk factors for the OPLL? Genes, of course, obesity, hyperinsulinemia, hypoparathyroidism, and there is associations with DISH, ankylosing spondylitis, ossified yellow ligament. The types of OPLL I won't repeat. And what will be the treatment? Treatment is conservative and surgical, of course. When are you going to consider surgical approaches? You're going to consider when there is a progression. Usually you expect progression when you have over 60% canal stenosis, less than 7 millimeters sagittal diameter, increased range of motion or instability, and when you have lateral OPLL. So what are the treatment options if you consider to go for surgery? You have, overall, you have anterior approaches and you have posterior approaches. Among the anterior approaches, we heard about corpectomy, oblique corpectomy, hybrid solutions. With posterior approaches, laminectomy, hemilaminectomy. We didn't hear about that. I will give you a few comments on this. Skip laminectomy, laminoplasty, and plus or minus instrumentations. So one of the main factors that we usually comment is age and implications. So what are the implications of the age? Old age normally will give you a rigid spine, and that will give you compensatory lordosis. I'll comment on that later. You will have your patients with reduced bone density, and you have to think about that. You have to go usually with multiple levels. With young patients, on contrary, you will have more flexible spine. You will have bone quality, which is better. You usually have to go with less levels, and your posterior muscles are still good, and you have to think about preserving them. That is a very good slide that I like. I borrowed this from Ed Benzel. You see that if you have anterior compression here, there is no point for you to do a posterior unroofing, because even if you do posterior unroofing, the anterior compression is still there. That is the rationale behind that line that we are drawing. That's why if you see that the key line is negative, that or positive, we have to tailor our approach respectively. So in general, if you see your patients in kyphotic angulation, you have to think about anterior approach. You have to see, if you see your patients in lordotic configuration, then you have to think more about the posterior approaches. This is a very interesting paper that I have found. Normally, as we said already, the normal lordosis is about 14 degrees. But with age, as you can see here, the cervical lordosis is getting more. And this is to compensate the increased kyphosis in thoracic and in lumbar spine. So that is why that is one of the implications of the old age. When you have old age, usually you have many of your patients will be in hyperlordosis to compensate the kyphosis, and this will draw you to go back and to do the posterior approaches in case you need to. Another paper that is showing another age-related implication. As you can see here, this author from Japan, he found that actually in the old age, when you go anterior, you reduce the lordosis of the cervical spine, which is a bit counterintuitive. But if you think the old age is more kyphotic because you will have poorer bone density, and then you can expect more subsidence if you go anterior. So I strongly advise you to think about your bone density, and you have to measure your bone density, and that is also one of the factors that will drive you back or front. If you cannot organize the DEXA scan, very easy for you to do is to go and measure the Hounsfield units. You can see here on that slide, this is a 20-year-old C6 with Hounsfield units about 300. And there is now good research suggesting that if you have below 150 Hounsfield units, you can expect complications. And if it's below 110, for sure your patient has osteoporosis and you have to treat it. So another factor that we were discussing so far, and I would like to recap and show you good research on that, multiple levels. Usually if you go anterior, you have to consider how many levels you have to address. If there is more than 3 levels, or if you have to do more than 2-level corpectomy, you have to think twice before you go anterior, because you have to expect complications. That is what research shows. That's what our experience normally shows. Long constructs usually will give you unstable construct. They will give you higher chance of failure. And then quite often you may need also posterior fixation. This is a slide that shows you the patterns of failure of the anterior constructs. And usually the longer the construct, the higher chance of failure. That's why you have to try to confine yourself to 2 levels corpectomy if you can. If you need to go more anteriorly, you have to probably consider also hybrid options. Dysphagia is one of the complications that I think is one of the most common when we do the anterior approaches. My cutoff normally is about 3 hours. If I do something, if I can do something for up to 3 hours, then I consider anterior. But if I think that it's going to take me more than 3 hours, I will think twice before I go anterior, because there is good research suggesting that if you go quite long anteriorly, then you can expect a lot of complications from that, and dysphagia is one of the most common of them. We had a good talk about the double layer sign. I will not repeat that. So to recap, for me, anterior approach will be reserved for young age, usually less than 60, up to 3 levels or 2-level corpectomy, good bone quality, kyphotic angulation, and up to 3 intraoperative hours time. So speaking about the posterior approach, again, we can go for laminectomy, hemilaminectomy, skip laminectomy, and then we can add instrumentation to our construct. It was already mentioned that the muscles are very important, especially if you talk about the muscles of C2 and C3. If you remove muscles of C2, 3, you can expect higher chance of kyphosing. So if you have to, for some reason, disturb C2, C3 muscles, better include that in your construct in case you are fusing. Post-laminectomy kyphosis is one of the most commonly discussed complications. And as you can see here in that review, different authors are reporting from 6 to 47% of post-laminectomy kyphosis. That is why careful selection and discussing and analyzing the factors that will give you that is very important. The authors of that paper conclude that although short-term results from cervical laminectomy versus laminectomy and fusion are similar, in long term you can expect complications, and that's why adding fusion to that construct will prevent you from complications, and the possible complications from fusion are not so high, and that's why we have to consider. So the same authors advise that if your lordosis is less than 10 degrees, you have to go posterior. If you don't have instability, you can go posterior. If you have instability, you have to go posterior. If you have neck pain, you have to go posterior. And if you have old age, you also have to go posterior. So another good paper that is analyzing different factors for complications and for post-laminectomy kyphosis. The factors that I have to mention, plus if you are very aggressive posteriorly, if you violate the facets, if you violate the capsule, if you detach the muscles from C to 3, you can expect post-laminectomy kyphosis. Alternative to laminectomy, we already had discussions about that, about the laminoplasty, different types of laminoplasty. I will not gonna stop here. This is a good paper that is analyzing the result from the laminoplasty versus laminectomy. As you can see here in the young population, laminoplasty is not preventing you from kyphosing, but in the adult age and in the adult patients and in the old age, that can be something helpful. So you can consider. Alternative to laminectomy could be a skip laminectomy, where, as you can see here, according to these authors, have to preserve the C2 and C3, and like that you probably will have a chance to preserve the muscles attached to that as well, and that will reduce the chances for kyphosing of your patients. Same paper, but a bit more detailed diagram on what exactly you have to do for the skip laminectomies. This is a good biomechanical study that shows you what is happening with different types of posterior approach. So the authors compared different types of laminoplasty and laminectomy. So they found that whatever you do, whether you leave the midline structures, whether you leave the ligaments, and or you move the whole posterior ligamentous complex plus the spinous process, the results are more or less similar. And really the big difference comes when you compare everything else with the laminectomy. So anything else is more or less similar and better than if you do only laminectomy in terms of the stability of your spine and possible kyphosing. Another good paper that I have found, that in case you're not good fan of laminoplasty, you can consider that as well. This is a Turkish authors which compared the laminoplasty with hemilaminectomy, and they found that there is no big difference if you compare laminoplasty with the hemilaminectomy in terms of how much room you will gain for your spinal cord. This is something that you can consider. And finally, I would like to conclude with this paper. This is a paper coming from Ed Benzel and team. They have evaluated posterior versus anterior approach in a big cohort of patients, and they have concluded that in case you can go anterior because your patients will do better and it will be more cost effective. So to recap for me, if I have to consider, I go anterior if I have young patients below 60, if I have to do less than 3 levels, so 2-level corpectomy, if I have kyphotic C-spine, and if I can do it within 3 hours. Also, my bone quality, the bone quality of my patient is important, and that will also drive me back and forth. Posterior approach, on contrary, if I have old patients, especially over 70, more than 3 levels, lordotic spine, bad bone quality, and if I have to go longer. And that was my presentation. Thank you so much.
Thank you, Nikolay, for being timely. We are getting late. Are there any questions? Any comments? Dr. Zen?
In what kind of circumstance we should do anterior and posterior approach, combine the approach? Do you think?
Of course, there is a gray zone, and there is patients which you probably have to consider anterior and posterior approach. But I will evaluate that on a case-by-case basis. For example, the case that was presented initially, and we were discussing, and some of you said anterior, some of you said anterior and posterior. Mehmet said that he will go posterior. I think that would be my approach as well. I would go posterior, and I will try to, because it was borderline kyphosis. It was not so kyphotic. It was kind of borderline case. And I think that probably in this case, posterior laminectomy plus.
Okay. Okay, thank you.
Okay, he disappeared, I think. There is one question, because I think we can answer that question. If pedicular screws are used, do you use extra step incision to place them in? Yes, I do this way. Actually, but I don't prefer pedicular screws in the cervical spine. If there is significant deformity, and correction of the deformity is the purpose of our surgery, you can use it because the fixations are more strong, and then you can also correct deformities with pedicular screws. And you should either open the wound too much by somewhat destruction of the muscles, or you must make extra incision to come in 45 degrees from lateral side of the incision. I think Jyoti is not there.
I'm here.
Sorry, Jyoti is there.
I'm there.
Do you have any comments?
No, I think what you said is right, because in applying the pedicle screws, we need a very lateral approach. That's one important thing which I also found.
Yeah.
So I have nothing more to say.
Right.